They must also be aware if there are any previously diagnosed cognitive disorders, such as ADHD. They should also be aware of the individual's history. Following a concussion, an athlete must immediately be pulled from play. They must remain out of activity for a minimum of at least 24 hours. An SAC test, which is a 5-minute test that evaluates the domains of orientation, immediate memory, concentration, and delayed recall. If the athlete cannot leave the field or get up, an athletic trainer must rule out and test for any other serious injuries, including cervical spine injury. Transport to medical facilities are not usually necessary, but may have to if conditions are too serious. Assessments and tests. Baseline tests are necessary for every individual participating in physical activity or sport. It is recommended that baseline tests are done annual. However, it is important that adolescents whose brains are still developing do them more frequently. The suggestion in the NADA position statement for younger individuals is every 6 months. Brains can continue to develop into the 20s. During a baseline test, athlete history should be noted, including neurologic history with symptoms and physical examinations. Objective evaluations should also be taken of multiple brain functions to assess neurocognitive performance and motor control. Medications should also be carefully documented and made available for post-injury review. The athletic trainers should consult with members of sport teams regarding best tools and assessments for the clinical setting and secure written approval from administration on what test to perform. Self-report symptom assessment. The use of symptom checklists or scales that assess symptom duration or severity in a standardized manner. They provide good sensitivity to concussive injuries. Due to the demands of athletes, an evaluation of concussion-related symptoms may also yield low specificity compared to standard clinical diagnosis. Athletes may also underreport symptoms in order to continue to play. Some checklists and scales that are commonly used include the Head Injury Scale, Graded Symptom Checklist, Concussion Symptom Inventory, and Sport Concussion Assessment Tool 3. Mental status testing. Change in mental status is a hallmark of concussions. However, loss of consciousness is present in fewer than 10% of patients, and post-traumatic amnesia in 25%. It is no longer appropriate to use questions about time, location, and the person. For example, what time is it? Where are we? What is your birthday? Instead, an SAC test is administered, evaluating the domains of orientation, immediate memory, concentration, and delayed recall. Sensitivity to this test requires that it must be done within 24 hours after the injury. Motor control assessment. Changes in motor control after injury have been documented in several occurrences, including with gait, postural control, and hand movement. The most common, however, being postural control, giving information from the vestibular and visual components of the balance mechanism. The sensory organization test has proven successful to quantify changes to the balance mechanism. However, it is limited by cost and portability. Within initial days of the injury, a balance error scoring system, BESS, can demonstrate similar injury sensitivity. Neurocognitive testing. In the past, pencil and paper tests have been administered, such as digit span, controlled oral word association tests, and Hopkins verbal learning test. Now, there are computer-based systems, such as automated neuropsychological assessment metrics, AM, Cogstate Axon, Concussion Vital Signs, Headminder Concussion Resolution Index, CRI, and Immediate Post-Concussion Assessment and Cognitive Testing, IMPACT. These tests provide data on information processing, planning memory, and switching mental sets. These tests should be done in a distraction-free testing environment, and a trained professional should interpret the post-injury data. Once concussion symptoms are asymptomatic, retests are done and are compared to the baseline. In order to start return-to-play protocol, athletes must be asymptomatic for at least 7 days, and their retest should be at prior to injury or higher. Post-injury management. Athletes should be removed from the sport and not allowed to return to play until cleared by a physician and no sooner than the next day. Athletes should also not be left unattended on the sidelines. Mental status should be checked regularly and monitored. If notable decline in mental status occurs, it could be a reflection of a more severe trauma. Focused examination of the athlete should be conducted daily. It is also important to note that each athlete and each injury should be treated uniquely and focus on the symptoms and restoration of motor control and the neurocognitive test. With acute recovery, an athlete should avoid physical activity and limit cognitive activity. When there are no more symptoms, objective tests will be taken again to compare to baselines. In most cases, athletes will demonstrate pre-injury performance levels. However, some can continue to have cognitive decline. Return to play decision making. In order for an athlete to return to play or start the return to play process, there are a few things that must occur. The athlete must no longer report concussion-related symptoms for at least 7 days. The athlete must have normal clinical exam and test results. The athlete must perform at or above baseline levels on all objective assessments. Though it is recommended that athletes may not return to play for at least 24 hours post-concussion, they are usually withheld for at least a week. The return to play progressions usually go as follows, and always have at least 24 hours apart. Stage 1 is no activity. They complete physical and cognitive rest. This is the recovery phase. Stage 2 is light aerobic exercise, such as walking, swimming, stationary cycling, but no resistance training yet. The objective of this stage is to increase heart rate. Stage 3 is sport-specific exercise. Now they can start doing drills, such as running drills in soccer and cone work, but no head contact. The objective of this phase is to start adding movement. Stage 4 is non-contact training drills. Progressions to more complex training drills such as passing drills in football or set plays in soccer. At this stage, athletes may start to slowly get back into resistance training. The point of this stage is to include exercise, display coordination, and increase cognitive load. Stage 5 is full contact practice. Following medical clearance, they can participate in normal training activities. The objective of this stage is to restore confidence and assess functional skills. The final stage is return to play. This stage is normal play of the game. Secondary impact syndrome and multiple concussions. Secondary impact syndrome is a second trauma prior to the first trauma fully healing. Primary concern of secondary impact syndrome is premature return to play. It should be noted that youth athletes require more time to recover, characterized by diffuse cerebral swelling with catastrophic deterioration. The best predictor for a second concussion or multiple concussions is history of at least one concussion. Not a position statement noted that collegiate football players who self-reported 3 or more concussions were 3.5 times more likely to get a concussion again There was also increased risk in high school athletes with previous concussions. Proper management of a concussion will reduce the risk of a repeat injury. Other considerations to think about. One of the other considerations is equipment. Athletes must be aware and educated about the limitations of protective equipment for concussion prevention. Athletic trainers, athletes, coaches, and parents should all read the warning labels associated with protective equipment. However, there is no current literature or strong evidence to support that equipment is a means of concussion prevention. That helmet use can reduce the risk of a more serious head and brain injury. However, there's yet evidence to support prevention. The next consideration is rest. In general, patients do not need to be awakened every few hours throughout the night unless they have experienced loss of consciousness, in which medical professionals will provide detailed directions of how to take care of the patient. During the acute phase, physical and cognitive rest are necessary. Activities of daily life do not need to be eliminated from a person's daily routine and may be beneficial to the athlete's recovery. However, some mental activities do require temporary leave of absence, including activities that exacerbate